So, is it clear, everybody? So, 1 minute for the presentation, 1 minute for answering. Mobile numbers, email, names have to be put in. And of course, the decision of the quiz master is final. So, we're ready to start with the timer. Let me know when you're ready. Okay. 57-year-old lady with shortness of breath, class 3, 7 days after thrombolysis. Now, this is your picture. So this is an MR picture. It looks exactly like the echo. And this is the delayed image after gadolinium. And the red arrow is pointing to something. Okay, this is the delayed image. This is the cine image. This is a patient who has had a thrombolysis and has now come to you. Focus on the red arrow. Cine image and the delayed on the right. The question is on the red arrow. So we are moving now, and these are your questions. A, is it an LAD partial thickness scar, or is it LAD no viability, or is it LAD ischemia, or is it LAD ischemia and viable myocardium? Remember the red arrow. That's the clue. So you have a minute now. Cine image on the left, and the right you saw the delayed image, and you saw the red arrow. These are your choices. Post-thrombolysis, patient has come to you, it's a delayed presentation. You've done the MR, there is a regional wall in the LAD, and then you have done the gadolinium. So you want to take this patient for revasc. Okay, so we're going to the next question. Is a 62-year-old male with recent chest pain and again delayed thrombolytic therapy. Recent chest pain, delayed thrombolytic therapy. This is again an MR image. This is something that was shown to you by Dr. J.C. Mohan a little earlier. This image is called the T2 FACC image, where we look for edema. And this image on the right is a post-gadolinium image, where we look for scar tissue. This is an LAD involvement. Patient is again a post-chest pain patient, and you've done the MR. This is the T2 FACC image, where we look for edema, and this is the delayed image after gadolinium. The red arrows are pointing to something in both the images. Focus on the red arrows. We had this lecture just post-lunch. Moving on. These are your questions. Is it LAD edema and a transmural scar, or is it LAD edema and only a partial thickness scar, or is there no edema in the LAD territory with a transmural scar, or is there no edema and only a partial thickness scar? So the left image is the T2 FACC, where we look for water in the myocardium, and the right is a post-gadolinium, where we look for scar. So these are your choices. The red arrows were the clue. You will be contacted through your phone numbers, so make sure they are legible on the paper after the corrections are done. Moving on, question number 3. It's a 72-year-old lady with worsening shortness of breath and polyneuropathy. This lady underwent an MR, and again this was discussed in the post-lunch session. This is a delayed image post-gadolinium, and this is what we found. And the red arrow is trying to tell you something. This patient had a gadolinium, and this is the scar image which you're seeing after 5 minutes. So this is what it is. Elderly lady, shortness of breath, we may call it a HFpEF, and she also has a polyneuropathy. Focus on the red arrow. Now these are your questions. First one is a global subendocardial scar with a high possibility of amyloidosis. The second is a global mid-myocardial scar and amyloidosis confirmed. And the third is no scar with most probably a triple vessel disease patient. And the last one is a patient with a diffuse scar with underlying coronary artery disease, triple vessel disease. Elderly lady with heart failure, having an MRI and a polyneuropathy. All of us can remember the HFpEF talk that was given and the European guidelines for HFpEF. Moving on, question number 4. 43-year-old male presented with atypical chest pain. He has a positive treadmill. Very common in your practice. A CT angio was done for this patient, and this is what was shown. You focus on the red arrow, and that is the plaque which is there. So the question will be on that, the red arrow. Focus on the red arrow. Patient with chest pain with a positive treadmill. Remember the sensitivity of the treadmill and look at the image carefully, because we now are also looking for the histopathology of lesions, or we are not only looking for quantification, but we are also looking for the histopathology of the lesions before we make a call. So the red arrow is showing, and these are your questions. So it's a moderate stenosis in LAD with a partially calcified plaque. It's a severe stenosis with a calcified plaque. It's a mild stenosis with a calcified plaque. And it's a moderate stenosis with a calcified plaque. So remember the lesion and remember the histopathology of the plaque, the red arrow. These are your choices. So plaque analysis is becoming a very important thing for us as we go forward, when we go for revascularization or medical management. Stenosis is important, but now we know that even plaque histopathology is important. We are seeing that with the IVIS and OCT as well. Question number 5. 45-year-old lady with recurrent VT and LV dysfunction underwent an MR. there are two images. The one on the left is what we would call a haste or a T1 sequence, and the one on the right is the delayed enhancement image. Focus on the red arrows to make sure you're looking at the right thing. So left image is the haste sequence that happens within 5 minutes of starting the scan, and the one on the right is the post-gadolinium image. We talked about this also in the post-lunch lecture. The first image happens to be that of the thorax, so in case some of you have not seen it before, it's an image of the thorax. And these are your questions. First is mediastinal nodes with scar, possible sarcoid. No mediastinal nodes, scar present, possible amyloid. No nodes and no scar, possible TB. And nodes are present, but there is no myocardial scar, possible sarcoid. You have to choose only one. Left image and the right image. The red arrow is to help you clue on to the diagnosis. Some of these I selected because this is what patients come to you with. They get it done from various diagnostic centers, so it's good to be able to see these images and make your own diagnosis. Question number 6. 48-year-old lady with shortness of breath, class 2, and recurrent VT. 48-year-old lady. And these are the images. Again, to give you a clue, this is PET-CT. On the left is the black and white image of the mediastinum, and on the right is the image showing the heart. These are PET-CT images, and this is a lady who came with recurrent VT, and this is what you've done. So 2 images and you'll get the question in 2 parts. Left is the chest and right is the myocardium. These are PET-CT images. Now the questions. PET-CT, as I said, there is nodal and myocardial FDG uptake. Answer number 2 is there is nodal uptake but no myocardial uptake. And the third choice is there is neither nodal nor myocardial uptake. And the last choice is there is significant viability in all the 3 coronary territories after giving FDG. Left image is that of the mediastinum and the right image is that of the myocardium. The red arrows are there to help you. Question number 7. 57-year-old male with shortness of breath, class 2, post-PCI to L6 5 years ago, recent onset breathlessness. He had a nuclear image. He had a nuclear test with Sestuma B. The upper image is the stress image. We made him walk on a treadmill, and the lower image is the rest image, which we gave sorbitol sublingual and did it. The red arrows again are pointing you to the pathology. post-stent patient came with recent onset breathlessness. You want to rule out anything happening to the stent. Focus on the red arrows. The above image is stress and the lower image is rest. And these are your answers. It's a MIBI scan, which I mentioned to you, with scar in the L6 territory. Answer 2 is a MIBI scan with ischemia in LCX, that's where the stent was. And the third answer is LAD ischemia, and the fourth is RCA ischemia. Remember the two arrows that's pointing to the diagnosis. First is scar, second is ischemia. Again, a very common sort of presentation in the outpatient. They go get their scans done and they come. Question number 8. It's a 28-year-old male marathoner with VPCs. You've evaluated him on the echo and it showed a septal hypertrophy, and then you did the MRI. These are MR pictures. And I will try to not put an arrow, but my arrow is pointing to the pathology which is shown there. I'm sorry. So this is a specific sequence which I talked about in my talk of heart failure. And this sequence does not need gadolinium. This is something I mentioned just to keep your attention. This is an MR sequence when you're looking at a patient of SCD and wanting to rule that out. This is a sequence which does not require gadolinium. And these are your choices. This is a CMR image, as I said. There is scar. B, this is a T1 map. And C, this is a T2 map. And this is a patient with a normal perfusion map. Remember, the clue is that I did not give gadolinium to this patient. I'm evaluating him for a suspected hypertrophy with VPCs. No gadolinium given. Question number 9. This is a 52-year-old male who presented with history of PUO. He's had a stent in a peripheral center in an emergency 1 month ago. This is a PET scan which I'm showing you, and the red arrow is pointing to the diagnosis. The upper images are FDG, the second level images are the CT, and the third is a hybrid or a combination of the CT and the FDG. Remember this story, he has had an RCA stent in an emergency primary in a peripheral center. Did well, came to us with the PUO. He's running high-grade fever and all his cultures are negative. No focus anyway. This is a PET scan. And these are your choices. PET CT, as I said, physiological FDG uptake, which is possible. B is FDG uptake in the stent. C is ischemia in the RCA territory. And 4, is it a PET MR actually with FDG uptake in the stent? So history of fever, cultures negative, and a prior stenting in a peripheral center. Again, something that is coming to us recurrently, commonly. When people get their stenting done in an emergency outside, we are starting to see these patients. And this is possibly the only way you can diagnose them. Question number 10 is a 62-year-old lady with shortness of breath class 3, 10 days after thrombolysis. And she underwent an MRI to look for a chance for revascularization. The image on the left is the delayed image, gadolinium, and the image on the right is the cine image, just like you would see it on a 2D echo. Image on the right is the cine, typical, and the image on the left is the delayed enhancement image after gadolinium. So we talked about this again in my heart failure talk, whether to send these patients for revasc when they come with a delayed presentation. And the arrows are pointing to the clue. And these are your answers. Partial viability in LAD with microvascular obstruction, no viability in LAD with microvascular obstruction, ischemia in the LAD territory, and the last one is partial viability and no microvascular obstruction. So 2 images and the red arrows were pointing to the diagnosis. We've talked about the scar and the transmurality of the scar. Patient is ready for revascularization, delayed presentation. There's only one right answer, so make sure you don't tick both, don't put 2 answers. The judges will not accept. Question number 11. So we have passed the halfway mark. It's a 29-year-old male with fever, shortness of breath, and multiple VPCs. He's come to the ER and he also has an elevated troponin with some ST changes. There is no ST elevation. There are ST changes and he has a troponin elevation. Someone was going to take him to the cath lab, but then we decided against it and we did the MR. So on the left is the cine sequences and on the right, in the middle, is the T2 FACC image that we were talking about and it was shown to you. And on the right is the delayed enhancement image. And the pathology is shown to you by the red arrows. The red arrows point you to the pathology. So you can focus on the middle image and the right image. Young male with chest pain in ER. And these are your clue. So is there a transmural scar and no edema? Or is there a partial thickness scar and no edema? Or is there a subepicardial scar with myocardial edema? Or is there a subepicardial scar and no edema? These are your choices. 2 images and the red arrows point to the right pathology. There is a T2 fat set image in the center and there is a scar image on the right. Young boy with chest pain, ST changes and troponin elevation. Question 12 is a 35-year-old male smoker with progressive shortness of breath. And this image I showed you. So that's a clue. This is actually a free hit. I showed this image in my talk. The left image is the cine image and the right image is the post-gadolinium scar image. And the red arrow is pointing to the pathology. The patient with worsening shortness of breath, and we are looking for the differentiation between coronary artery disease and a non-ischemic pathology. Okay, this was there in my talk. And these are your choices. Mitral regurgitation with no scar, mitral regurgitation with a partial thickness scar, mitral regurgitation with a transmural scar, and no mitral regurgitation and no scar. So this was a cine image. I think you all picked it up. The left was the cine and the right was the delayed enhancement image. We've tried to make it as objective as possible so that it's easy to make the education. MR is mitral regurgitation and there is a choice of scar. Question number 13 is an 18-year-old boy with recurrent palpitation, young boy with palpitation. These images should be familiar to you. They are all cine images of the same patient, different cut sections, and they tell a story. These would be exactly what you would see on the echo. These are all cine images, same patient. I'm not showing any red arrows because this is something familiar, and I think we also discussed this in our evaluation of HFpEF just 2 hours ago. So watch the pathology. This is cine image. This would be exactly what you would see on the echo. So there's nothing different on MR. We see the same things. And these are your choices. LVOTO with SAM and MR. Left ventricular outflow tract obstruction is present with SAM and significant mitral regurgitation. No LVOTO and SAM and significant MR. Third is LVOTO with no SAM and only mild MR. And the last is LVOTO with a scar and significant MR. So which is the most optimal? Remember, I showed you only the cine images in this particular patient. Most of you would have guessed that this is a HCM patient, but please look at the answers carefully. Question number 14 is a 68-year-old male with a recent CVA. This is a cine MR image. It would be similar to what you would have seen on echo. So focus on the leftmost image. I think you saw that. And on the rightmost image, I have put a red arrow which is pointing to the pathology. Again, this is a very frequent test recommended in patients with stroke. So the pathology is the red arrow. I'm sorry, I can't play it again because it's shifting the slide. So the leftmost picture is showing you the valve. It's pretty straightforward even on the base image. And the rightmost is showing you the pathology. The red arrow is pointing to it. Patient came with a stroke. So the answers are bicuspid aortic valve and a penetrating atherosclerotic ulcer. 2 is a tri-leaflet valve and a PAU. 3 is a calcified aortic valve, and 4th is an aortic aneurysm. Patient came with a stroke. We have looked at his valve and we have looked at his aorta, and we have done this without a single ml of contrast, the CKD patient. So we decided not to do CT as we would have done, but we went ahead with a plain MR study, no contrast. The red arrow is pointing to the diagnosis. Question 15 is a 72-year-old gentleman with worsening shortness of breath and chest pain, elderly person, and he's come to you with chest pain and breathlessness. So again, the pictures would be similar to what you would see in a parasternal long axis on the echo. So nothing different. We're not asking you for any specific MR pathology, but just like you would see it on the echo. I think it's pretty self-explanatory, but watch the image closely. Same view of a parasternal long axis on echo. These are MR images, they are only cine images. So very similar. Hope you all had the chance of appreciating the wall motion, but so diagnosis, mild aortic stenosis with associated HCM. Second, severe aortic stenosis with associated HCM. Severe aortic stenosis with no HCM. And no aortic stenosis with only HCM. Your choices. The MR image, as I said, is exactly what you would see on echo. He is an elderly person with shortness of breath. Question number 16 is a 62-year-old male with worsening shortness of breath and a recent CVA. Now this picture again on the left is exactly what you would see on an echo, and the red arrow is showing you the pathology. It's a typical two-chamber view. Note the wall motion carefully. And the picture on the right is a T2 FACC image, which we talked about, which looks for water in the heart. The picture on the right is a T2 FACC image, which looks for water in the heart. It is not a scar image. Gadolinium was not given to this patient, again because of creatinine issues. So the left one was the cine that you would see in echo. The right is T2 fat sat image. First choice, is it a CTA showing fresh thrombus? Second, is it CMR with ischemic heart disease and an old thrombus? And C, is it CMR with ischemic heart disease and a recent thrombus? Here, I would like to mention that there is a possible IMH also. Possible IMH for question number C. So you can just note that IMH is part of this answer. And D is a DCM with a recent thrombus. So answer C, please note that it's ischemic heart disease, recent thrombus with an IMH, intramural hematoma. It's not there in the print, but C is recent thrombus with intramural hematoma. (17) is a 58-year-old male post-bypass with GRD, and he was sent to me with a cardiac mass on the echo. So I did the MR, and you watch the cine carefully. It's a typical 4-chamber cine, and the RA, RV is there anteriorly. I will try to play this again. And I have highlighted the mass on the left side. This is a haste image. It's a T1 sequence. And this is a sagittal section. And I've highlighted the mass in green. And the same patient has the cine image. And you can see. I'm going to make an attempt to make it play again. Just see if I can do it. So cine image on the right, left is a sagittal image. So is it an LA myxoma? Second choice, LA thrombus. He presented to me with the mass. LA extrinsic compression by a stomach herniation. And last choice, is it an LA extrinsic compression by a mediastinal mass? 4 choices. The left image has the clue. Some people call it a diaphragmatic eventration, some people call it hiatus, but that's what it is. So mass in the LA came for evaluation. On 2D echo it looked, could not differentiate it. Question number 18. 28-year-old male underwent cardiac screening prior to NBA selection in the US. He has an abnormal ECG for a long time. This image is a typical 2-chamber view of an echo. Consider it as an echo image. The pathology is highlighted in red. This is a cine MR, which is absolutely the same as a 2D image. 2-chamber view with a dilated left atrium. Young boy with an abnormal ECG had to be screened as the practices in the US for collegiate basketball championships. And anybody there with an abnormal ECG has to have an MR. These are your choices: apical HCM, hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy, and EMF. 4 choices. Only cine images on MR is absolutely the same as what you would see on a 2D echo. The answer, of course, is C, extrinsic compression, stomach herniation. And 18, I think all of you got. This is nothing but apical HCM, very clear, spade-like LV cavity. That's the very thick apex, dilated left atrium. I've not showed you any other images, so EMF will not be part of this. And there's no LVOT obstruction, so there's no obstruction at all. So 19, again, is the L6 total occlusion. And again, just to show you this series of MR delayed images, you can see the thinning here in the circ territory. There is more of translation pull here because of the vigorous contraction of the other segments. So that's the clue on echo, thin compared to the IVS. And this is the real sort of clue. It's a transmutal scar. The entire, whatever left of the L6 has got the delayed enhancement in white. So white is bad, white is scar on MR, and so therefore we are using A, CMR non-viable L6. Nothing to do with the LAD and RC. And the last question, may be tough for those of you who have not seen, but this is really easy because there is a perfusion defect exactly in the same area of LAD. All the other areas are good, yellow is good, and this area which I showed just normalizes in the rest. And that really means only one thing, that there is a large amount of ischemia. And this picture is also very telltale. Dark image and completely becomes normal. This person should have a revasc as early as possible. So it would be C, viable and ischemic. You can't have a non-viable myocardium and have ischemia. So D is completely off. And yeah, so that's it. And it was ischemia, so it's C. Okay, so this was no ischemia. That's not true, and it's not non-viable. It was viable, and there's ischemia. So that's it, everybody. Thank you very much again.